Okay, and good afternoon, and welcome to the Davies Use Case webinar being presented by Duke Health on early recovery after surgery. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety Initiatives at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence, the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from Duke Health, and I will turn the presentation over to you all, and you can start when you're ready.
Good afternoon. Thanks a lot for having us. We look forward over the next few slides to share with you our success story relative to enhanced recovery after surgery and different IT innovations that we have enjoyed. I'm Julie Thacker. I'm a colorectal surgeon at Duke, as well as the medical director of our clinical research unit and the medical director of our evidence-based care around the time of surgery program.
My name is Chris Vail. I'm a physician assistant with our trauma surgery group here at Duke, and I serve as the IT liaison for all of our surgeons.
Just quickly to introduce our work relative to enhanced recovery. As a colorectal surgeon, I recognize that we here at Duke and all across the nation have high rates of readmission and secondary complications from colorectal surgery. Because of this, we worked hard to institute some evidence-based care around the time of colorectal surgery. Doing this was fairly straightforward when we were just addressing the problem with 3 providers at one hospital. But as our group grew, as well as we started having more IT interventions available on the patient care side of our work, we wondered what we might be able to do to marry our efforts with those in IT. Specifically, what we started with was almost an entirely paper system where we put in place a care protocol with enhanced recovery starting before the time of surgery. We educated the patients, worked on them to make sure we set expectations relative to pain management and what their course around the time of surgery would be. And we made sure that the entire system taking care of our patients, from nursing, transporters, and all of the other MD providers in the system, understood what we had planned for them and helped our patients meet those goals. Simply putting this small program in place, again with 3 MD providers on the surgical side, we were able to make the improvements shown here by decreasing our length of stay and decreasing readmissions and the other secondary complications that we had seen matching the national outcomes for colorectal surgery. With this, we wondered, by putting things in place with some IT solutions, what we might be able to further improve.
So some of our first initiatives around coordinating care and identifying these patients was really that whole idea of identifying the patients. We had protocols in place, and we had done a good job of educating all the providers and nursing staff and anesthesiologists involved, but we thought we'd maybe take this a little bit further to better identify these patients at the various points of care in easy methodology and manners for all those involved. So one of the first things we did was implement a button when surgeons or their staff are posting a case to identify, is this enhanced recovery patient? What that then allowed at the time of case posting allowed for driving special icons across the whole entire care continuum. Here we see this highlighted in the pre-anesthesia testing clinic. Having this available for these providers allows the anesthesia staff who are doing their part of getting the patient ready for surgery to further reinforce the expectations and ideals of the ERAS program. Additionally, going on to the day of surgery, additional icons and highlights were able to be made on the anesthesia boards so that at a glance, anybody taking care of that patient in pre-op holding knew that that patient was an enhanced recovery patient. So they were again able to reinforce kind of the expectations and knew what the outcomes and the goals for the patient were that day. Other preoperative interventions involved both written and IT interventions, giving the patients identified for colorectal surgery a dedicated printed booklet, but in addition also developing an iOS-based app where they could watch videos, go over their instructions and other outcomes in more detail, and so that no matter which learning methodology that our patients chose to pursue, these would mirror each other and it would kind of provide education across the board. Hope to have an Android version of this in the future, but iOS for now. Additionally, some of the things that were designed to help nursing continue to maintain the patient's care were best practice alerts generated from the surgeon's postoperative orders. We put in orders in a standardized fashion to say to all the nurses taking care of these patients, please base this patient on enhanced recovery protocol, initiate the education pathway for these patients, and also kind of an overall care plan. If they didn't have a chance to enable that within a 24-hour period, a best practice alert would then fire to let them know, hey, could you please add this? Again, just another way to reinforce that all these patients are being cared for in a similar like-kind manner.
Because we had fantastic nursing engagement from the beginning of our program in 2010 through our paper model and on into the electronic model, we started looking at our outcomes relative to patients being identified and how well they did in the system. We found that almost every time we had a nursing intervention entered into our IT version of enhanced recovery, it was being fulfilled. So we knew that we had excellent compliance. Interestingly, though, one of the main tenets of enhanced recovery is avoidance of systemic opioids. Being given narcotic medications around the time of surgery can complicate postoperative recovery from colorectal surgery. We looked to see how many doses of narcotic medication our patients were getting, and particularly when we used a block that should help us use less. And we found that there were very high numbers of doses being given in the immediate post-operative anesthesia care unit. The numbers inside the operating room remained low, and the numbers once the patient got to the nursing ward were low. So we investigated this further and found from interviewing our nurses in this particular setting that they did not have any way to help the patient who was just awakening from surgery to manage their pain if an epidural was in place. Specifically, we had not empowered the frontline providers with a way to manage the patient in the best enhanced recovery method. This is a screenshot of what was created to help the nurses in that situation have something besides systemic IV opioids for rescue pain management. With this in place, we were able to watch our implementation of this intervention and then see that our systemic opioid use decreased as we were able to increase the use of the epidural order set. So yet again, an intervention with IT intent really based on patient care.
So some of the other measures we were tracking were uptake in utilizing the appropriate content that we developed for providers and nursing, and you can see some of the metrics here. So I'm going to start in the top left. One of the other service lines that was most recently targeted in the fall of 2017 was urology providers, and specifically those undergoing prostatectomy procedures. you can see in the top left, their kind of use of a standardized preoperative order set in the early summer was basically non-existent. And you can see the blue bars start ticking up as we rolled out education. That we now have the providers starting to utilize the standardized content. And now below it, specifically in the bottom left, when we developed procedure-specific order content for them for all of those patients undergoing radical prostatectomy on the ERAS pathway, we have 100% adoption of appropriate order set utilization. Also, on the top right, as I alluded to earlier, we started using an ERAS indicator ordered at the time of a case posting by surgeons or their surgical staff. Again, as we started to roll this program out, you can see that the utilization of that indicator increases. Bottom right metric, ERAS care plan. This is what we alluded to on a prior slide about best practice alerts being sent to nursing and also standardized orders alerting nursing that we'd like you to now implement this specific care plan and education template for these patients. And you can see by the fall of 2017, going into early 2018, we have 100% utilization and adoption of these tools for other providers. And as we move along, we had already been doing good from a readmission and length of stay standpoint from this service line, but as we introduce these additional tools from icons, new education pathways, care plans, and templates, we were yet again able to bring down the overall length of stay from 5 days to 4 days on average, resulting in about a 28% reduction from the fiscal year 15 that was kind of already gauged as a very high bar for the program. And again, this is just looking at a much larger curve, and it's incorporating some of our sister facilities. We have a facility at Duke Regional and Duke Raleigh at 2 of our other hospital sites. And as we implemented the full toolkit for these facilities to include everything that we had learned iteratively for our main university hospital program, they were able to bring their readmission rates drastically down from 20% down to 5%. So overall, for our whole entire health system, once we look at the books for all 3 of our hospitals, our overall readmission rate from fiscal year 15 to current was around 50% reduction. And these are just some of the fiscal year to fiscal year comparisons as we look at all of the enhanced recovery service lines that have been brought up, be it a service line or procedure-specific protocol. And almost universally, all programs continue to do better when we look at standard readmission rates, which is a huge outcome metric that is reportable to many insurers and the government for quality. So we kind of discussed a lot of the interventions in the parts of the pathway. So this is just a slide to kind of wrap it all up from how the patient starts, married with interventions. Starting in the top left, after a consultation with the provider in clinic, the patient's identified as being appropriate for being on protocol. They're given appropriate education and also access to the iOS app at that point in time. The surgeon's office requests their appropriate case. The ERAS flag is identified within this. And there's also a secondary question to identify whether this patient is anticipated or not anticipated to have an epidural pain catheter placed for their case. Then, when the patient arrives for pre-anesthesia testing, the icons on their boards, when they open up the patient's chart, allow them to reinforce those patient expectations on the ERAS pathway. Moving on to the day of surgery, again, we have icons all over the various touch points for that patient to allow those frontline staff on the day of surgery that this is an ERAS patient, and that additional icon of whether the patient is going to have an epidural or not allows the appropriate anesthesia team to staff for the appropriate manpower and have the appropriate conversations with the patient on the day of surgery. Once in the OR, anesthesia has their protocols embedded within the electronic healthcare record, and then after the case, all of our surgeons have access to the standardized orders that are then implemented. In the PACU, as we mentioned, we have new nursing protocols and orders that allow for enabling them to now use the epidurals that are in place for acute pain control needs as opposed to defaulting to IV narcotics. And once the patient arrives on the floor after that, the surgical team's orders that are standardized are now utilized, and these trigger floor nursing, patient care, and care plans and education templates so that the patient and their families can have their progress and goals continually reinforced up to the day of discharge. And the patient meets the discharge criteria once they've met all care and education milestones and they're medically ready for discharge.
What's been most exciting for me as a 100% time clinical provider within Duke Health has been that our protocol starts with patients mentioned in the first step all the way through to the last step. And being able to bring in new clinical information as to how we'd like to care for our patients and having it reinforced with IT solutions has been essential. We have been able to reinforce patient education, nursing education, make sure that providers are compliant to the protocols that they have helped create, as well as we have different auditing functions to help us define the next step of improvement relative to our continuous improvement plan for enhanced recovery.
And one of the greatest lessons learned for myself is I've spent so much time working with our providers, making sure that they had their protocols and orders and other tools readily and available for them. But the more and more we continue to iterate, the knowledge gap became quite aware that we needed to develop a lot of tools for all participants who are part of the patient's care. This includes nursing, wound nurses, and anybody who might be involved in this patient's care, and really developing those additional tools to bring them into the full entire process to continually reinforce the patient's goals, progress, and plans, and also help educate the families has just been a win-win across the board. So for the end and summary, for the value of this program and all the effort we've done here, kind of moving patients through the whole entire care continuum from the preoperative to post-operative phase, allowing orders and protocols and care plans and education, allow the nurses to provide better care. That, in turn, having everybody on the same page has greatly enhanced the patient experience, from alleviating their stress throughout a very stressful process, targeting their pain control, decreasing the length of stay and complications, and just, again, overall care and the patient experience, while at the same time driving down the median length of stay and also greatly reducing 30-day readmissions across all of our surgical platforms at all 3 hospitals.
Thank you for including us in your presentation and for your attention.
Okay, thank you both for that great presentation. I just want to remind other listeners where to go find Davies information. That can be found on the HIMSS Davies website at hims.org/Davies. There you can find more webinars, use cases, and information on how to apply for the Davies Award. Once again, thank you very much for the presentation.